with the Saudi Critical Care Society, and really pleasure to be with you guys today. So I have no conflict of interest, and I thought for this discussion to really cover the basics really well, discuss the mechanism of acute lung injury and trauma, briefly outline the general ARDS management, and a bit to explore about the ECMO, what it is, just briefly really, and then really look at the data of use of ECMO in trauma, because as you said, it's a unique condition. Most of these patients come with a bleeding. They have contraindication for ECMO. They have a traumatic brain injury, intracranial bleed, and all these complications. So we will review some of the data in use of ECMO in general and in trauma, and then we'll move a bit to discuss Qatar ECMO experience and trauma. And in the last, I will review briefly about our most recent paper that was published in Nature about this topic, and then we can have a question and answer session. So this is the typical scenario, usually a young male, road traffic accident, traumatic brain injury, polytrauma, severe ARDS, and you do the usual management, which is protective lung ventilation, sedation, paralysis. If you're lucky, you can prone them. If they do not have contraindication to prone, some of them will recover, will do very well. Some will be very, very sick, like this patient with refractory hypoxemia, severe hypercarbia, and severe acidemia. And you can see their vent setting is already injurious ventilation, 100% FiO2, PEEP of 18. The plateau pressure is 45. And despite all of that, you have this interesting phenomena where the PaO2 and the PCO2 switch their numbers. So the PaO2 is actually 42 and the PaCO2 is 120. So we see these kind of thing. And if you look to the lung, it's white out and they have a severe ARDS. And with that, they also have this particular patient have intracranial traumatic brain injury. So what really to do, what option? Because if you leave them in such way, the survival is actually very, very rare that they can survive. So going to background, trauma is still the most leading cause of death in young adults worldwide. In the Gulf region, is the #1 cause of death, especially in Qatar. Blunt thoracic injury and acute respiratory failure is usually directed for maybe 20 to 25% of the mortality in trauma. And if you look to the mechanism of injury for a patient with trauma, direct injury, you can have pulmonary contusion. And as you can see, the alveoli is full of blood. It's the lung is full of blood in the airway and in the alveoli that prevent gas exchange and give you shunt unit. The more you have the shunt unit, the more you have of hypoxemia. You could also get the vent infection. So majority of these patients will, with traumatic brain injury in particular, will not able to be protecting their airway, and they will have aspiration pneumonia that could be severe, chemical pneumonitis that can be later on be bacterial pneumonitis. They can get ventilation-induced VAP, vent-associated pneumonia as well. So those are direct causes. Indirect as well, you can have many of these patients will have fluid overload, massive resuscitation protocol, and they can get as well in fluid overload state that complicate the picture. Interesting phenomena, many will get also immunological lung injury, which could be indirect cause from cytokine release and stress trauma that increase vascular permeability. We used to call it shock lung. That can give ARDS, transfusion-induced lung injury, and many other immunological causes that can affect the parenchyma and the alveoli. But it's not only that. So these sort of the summary, you can have actually all of them combined from the alveolar standpoint of view. Other than the alveolar injury and the lung parenchyma injury, you can have airway injury. So you will see patients who have tracheal rupture, right or left main bronchus dissection with associated paratrauma, tension, pneumothorax. Very, very difficult to ventilate these patients. Although the lung average injury score is not that high if they have isolated lung injury, but they carry significant mortality and morbidity with difficulty to ventilate them. It's not ARDS, but it's if they have component of pneumonia on top of that, it will be very difficult to treat them. So And the third is a pleural-related illness. So obviously you can have bleeding. So you can have hemothorax that can be severe and can cause hemorrhagic shock. You can have pneumothoraxes as well, bronchopleural fistula, as described before. And these pretty much is, you can have all of the above really. Airway injury plus ARDS plus pleural-related injuries. And management of such patient is a dilemma. It's difficult sometimes. And with a standard treatment that you do for your typical pneumonia patient is a bit different and need really a stratified strategy. And when you combine that with a traumatic brain injury, these are a set of patients that have probably not the best prognosis, but they also have, difficult to identify who will get better and who will not. So the prognosis mainly depends really on the neurological recovery. So you can fix the lung, but if their brain is not recovering, that will add to the mortality. And they don't tolerate severe hypoxemia and hypercapnia very well. And this have to do with a brain crosstalk with the lung. This is very interesting paper that was published recently, 2022, that talk about that. There is so many communication between the lung and the brain. Hypoxemia will give you cerebral hypoxic injury. Hypercarbia can increase your intracranial pressure. RV dysfunction from terrible ventilation or increased pulmonary vascular resistance can give you cerebral venous hypertension that can complicate the picture with increasing intracranial pressure. Obviously, the sedation that you are using to manage intubated patient can give you cognitive impairment. But it's not only the lung to the brain, is also brain to the lung. And we know traumatic brain injury alone can induce neurogenic pulmonary edema. Encephalopathy and the delirium that's associated with that will increase your work of breathing and can precipitate sudden respiratory arrest. Respiratory depression and phrenic nerve involvement can also affect weaning of these patients from mechanical ventilation. So there is a lot of communication between the brain and the lung. And this paper actually also just having a nice summary, I think is good. I'm referring to, people can review it, very nicely explaining some of these crosstalk. So the traditional ARDS management that you do for your patient with ARDS and trauma might be a bit different. We are not talking about mild ARDS that you can treat with NIV, mostly between moderate and severe ARDS. And for the moderate, we do neuromuscular blockade, high PEEP, bronch position, low tidal volume ventilation for everybody. When you go to severe, it's pretty much the same, but you go up with a higher PEEP, and then you can have rescue therapy. Unfortunately, bronch position, one of the best treatment for severe ARDS, not always possible to do on patient with trauma, polytrauma, and traumatic brain injury. And if you go to rescue therapy from that, high frequency oscillation is not being used now in adults anymore. So you pretty much have ECMO as your next step. So what does ECMO stand for? ECMO is extracorporeal membrane oxygenation. And it's pretty much have this interesting device that have a pump with a controller, oxygenator with a gas cylinder attached to it, and tube and cannula that drain the blood, pump it up to the membrane, get oxygenated, and CO2 gets removed, and then it return back to the patient. And depending on the configuration of the ECMO, we name it in different names. The most commonly used is veno-venous ECMO and veno-arterial ECMO, and then there is a hybrid configuration. Veno-venous ECMO is when you drain the blood from the venous system and you return it back to the venous system. And you can return it in different way, from FEM configuration, which probably is the most commonly used in trauma patient, from jugular, and you can have bicaval cannula. You return the blood in the venous system and you return it back in the venous system. This is pure respiratory support, has no effect on the cardiac output. If you go to the veno-arterial ECMO, you drain the blood from the venous system and you return it back to the arterial system, bypassing the biventricle. So that's give you a cardiac output support and some respiratory support as well. And it also have different configuration. I thought this is a video just to show how we do a FEM cannulation in a trauma patient, because, with the polytrauma and the bleeding, people worry from the risk of the bleeding. Although it's It's not that difficult. In this particular patient, we have no cut at all. So it's just a needle over guide wire, and then we do stepwise dilatation from 6 French, as you can see, going up to 8, 10, 12 stiff guide wire that are used. And we continue do dilatation. This was a bedside in the trauma intensive care unit with an ECMO consultant on the right and a trauma surgeon on the left, working together with ECMO nurses, trying to establish the access. So, and now this is the cannulae. One is the access that have multiple stage, and then the drainage, the return, which they are placing it now. Once you place it, you flush it, make sure it doesn't get clotted, as you can see in this video. And then you put the other drainage cannulae through the other femoral vein, goes smoothly and easy. And you do the same, you flush it to make sure it doesn't get clotted. You confirm the position by ultrasound or fluoro. In this view, you can see it in the right atrium, the return and the access in the cable IVC. So it's something that can be done by intensivists, can be done by surgeon. And the next step after that, just to go back to the same patient that we discussed, you can see from the screen the alveolar unit that have a shunt, remarkable shunt. And this particular patient that we discussed earlier, very high setting in the ventilation, PO2 of 42, SAT of 70, white-out lung, it's a severe consolidation. When you add them and you cannulate an ECMO, so it works this way, the blood come through the pump by negative pressure, it go with a positive pressure to the membrane, get oxygenated, CO2 gets removed, it returns back to the right atrium, pulmonary artery, and you see it go through the capillary already, the shunt oxygenated already, blood that bypassing already that shunt because it doesn't need ventilation, and the blood gas quickly usually get improved most of the time. And then you don't need this injurious ventilation anymore. That gives you the support that you could not achieve otherwise. But you need to pick your patient who will benefit from this treatment. These are the patients that I think, in my view, are refractory hypoxemia that is drone resistant or have contraindication to drone, and you cannot achieve protective ventilation with the very, very severe lung injury score. So usually in this course, once you can see in the Y and X axis is the support. Before ECMO, they are 100% mechanical ventilation support, and their native lung function is close to 0. Once you add ECMO on, you drop the mechanical ventilation support significantly, and you wait. So you treat the lung at this time, and it's vary from patient to patient. In trauma patient, this is take usually up to between a week and 3 weeks, I think is the average for trauma patient. Usually within 2 weeks, most of them, they get better unless they develop another complication. And then you will slowly see the lung start function to improve, and you go to the weaning, you drop your ECMO flow, your weaning strategy, and then you wean them from veno-venous ECMO. So what are the data in use of ECMO in a trauma patient? So believe it or not, the first case in adult was in 1972, and it was actually done on a 24-year-old with polytrauma. And you can see the old technology, but despite all of that, this patient survived, and this is give a hope for the ECMO community in adult, but also in the trauma setting, because that was actually a severe polytrauma who have a contraindication to anticoagulation, but he will survive. If you look to the other data in trauma, not as many, but obviously we cannot go without talking about CESA trial and EOLA trial. Briefly, so CESA was done in the UK and show significant survival benefit for patients who are treated in ECMO centers and severe respiratory failure ECMO centers, comparing to none. This is one of the reasons actually we established our program in Qatar to have one center for the country to start the service. EOLA trial, on the other hand, shows, you can see the liaison between the ECMO and control group. However, it did not reach a statistically significant. And when you look more to the data, 28% of the patient in the control group who receive ECMO in the conventional group did receive ECMO actually for refractory hypoxemia after randomization. So that's pretty much, I think, affected the result. And if you look to their data, you look at the number of thromboposition on the study, very high in both groups, which is great, but you cannot get this number in trauma patients. So significant number of trauma patients will be deprived, unfortunately, from position for one reason or another. You can bone open abdomen, and we do that, but there is some patients you can't just move them. You know, they are very non-movable. So that makes things difficult. So if you look to that other data in trauma, I got this paper in 2020. That's a systemic review, really, that looked up 58 paper with about 548 patients included in the study. The most common mechanism of injury, as everywhere, is pretty much is the RTA, followed by fall. And most of these patients actually have polytrauma, blunt chest trauma, abdominal trauma, and TPI. Survival is astonishingly good, close to 70% survival, with the average injury severity score of 38, which is a high number, but it obviously can be worse. But despite that, they have a good survival. They have bleeding complication is there. We cannot deny it, but it can also be with thrombotic complication as well, DVT being the most common, and oxygenator failure, and probably could be related that the team may be running heparin-free circuit. Cause of death in this review was multi-organ failure and sepsis as the most common, plus additional cause. So I think it's really important to find what is the optimum time really to start this treatment and what is the right patient. And the problem with the TPI is difficult to delineate who will benefit and who will not. Because some of these patients will progress to brain, and no matter what you do, it's a game over. And the optimum patient also is not very easy to delineate, and we're trying to study this more in review. So unfortunately, you will have lots of great trauma center that they don't have ECMO. You will have a great ECMO center that they do not have trauma level 1 by US definition, and that's make to study this group of patients is very limited. You need this. You need the centers who do trauma and do ECMO very, very well. And we need more of these centers so we can do more multi-center randomized trial to be able to understand this problem better. So moving on to Qatar trauma ECMO experience. So Hamad General Hospital is the main hospital that we work at, tertiary coronary center. It's University Hospital for Weill Cornell and Qatar University, National Ambulance and National Cardiac Arrest Center, but it's also accredited Center of Excellence as a level 1 trauma center. And it's also Center of Excellence as well, good level that is going to be platinum hopefully next year. And that's allow us to study this population a bit more. And that was really the first case that we done on trauma. Was actually our 4th case in 2014. Very similar story of I mentioned before, severe traumatic brain injury severity score of 54, severely hypoxemia. You can see the lung is completely consolidated. And I think, that was a great start. We're lucky, that this patient really have 3 weeks of BV ECMO, did very, very well. It took her time to recover completely. She's back to her family, got married and have kids. But it gave us the courage to do more cases in trauma, and we run a heparin-free circuit, and we learned big deal from this first case that let us continue and carry on to deliver more. So we done to date up to 2020 about 22 cases, and you can see the average injury score on this patient is high, it's 49, comparing to the meta-analysis study, which was 38. And the median is still high, 47. We have ranged from 12 because I think we have one case that was just isolated tracheal injury and bronchial injury without any other body trauma. So that dropped your ISS score. But the median you can see of 47. So it's pretty complex trauma patient. And here in blue, you can see the systemic review. In red is Qatar data. It's very comparable. Cause of injury, RTA is the most common. Followed by fall, not significant gunshot or stabbing in Qatar. And if you look to the injury as well, it's very comparable, except TPI for us is pretty high, 63% versus 23. And maybe that's why these patients have a high average injury score as well. Survival, despite that, very comparable to the systemic review, close to 70% in both sides. And moving now to the most recent paper that is a combined work by the trauma team and the ECMO team, really looking at the outcome of post-traumatic ARDS and patient requiring ECMO and comparing them to a similar group who did not need ECMO. So I will do a quick review of this paper. I think it's opening the way for further study. This was a retrospective study in one center, single center. However, this single center represents the whole country, so it's diverse because it gets all the trauma patient come to the one center. And we looked at the primary outcome of 30 days post-admission mortality and more than that, follow-up mortality as well. Then these are some of the secondary outcomes that we will touch base on. It was easy to identify the trauma patient because their number was not high. So we have 22 up to 2020. We done 1-to-3 matching ratios. So we included a trauma patient with ARDS who did not require ECMO, and we tried to match them with the same group. So total of 85 patients went on the study. We use different scores to categorize the patients as everybody, shock index, injury severity score, SOFA score, RISP score to assess ECMO survival. But Murray Long injury score, I think, was very interesting. That was the only one that completely different between the two groups. So Murray Long injury score, it's score up to 4. It's 4 variable. Each one can be up to 4, and then you need to divide the whole number by 4. So PF ratio, you can see the categories: chest X-ray, quadrant infiltrate in the chest X-ray, the use of PEEP, and the compliance. So if you, let's say your PF ratio is less than 100, you have a 4-quadrant infiltrate, and your PEEP more than 15 or equal, and your compliance is less than 20, you score 4. That's the highest Murray Long injury score. Yeah. If you have any other combination, you can score anything from 0.25 all the way to 4. So if you look to the group, so the green one is no ECMO, the red one is ECMO, and these are different variables. They are all comparable with non-statistically significant difference, except, sorry, before that is, this is the number of TPI and chest injury and abdominal injury. It's pretty high as well. But the Murray Long injury score was really different with a p-value of 0.001. That maybe have some effect on the study, but look at the no ECMO, their Murray score is only around 2 only, versus ECMO, which is 3.5, 3.35. And one of the reasons it dropped, because I think it's higher than that, is some of the patients have a bronchial and tracheal tears. So that's affected the overall Murray score, because majority are 3.75 and 4 that we take for ECMO. And you can see the percentage of the patient who has severe lung injury on the no ECMO group was very low, actually 11% versus 86% on the ECMO group. The reason for that, I think, again, because few patients had injury to the airway and one had the ECMO. But the rest is 19. Their injury score was pretty much Murray score of 4. Yeah, so that's, I think, also have some contribution. If you look to Kaplan-Meier survival curve, you can see there is a delineation between the ECMO and patient who did not have ECMO. However, it did not reach statistical significance for various reasons that we mentioned some of them. But if you go to the subgroup analysis and you see in a mild to moderate lung injury, there was really no difference in the use of ECMO or no ECMO, because the survival in no ECMO group was actually good, which is, it does make sense. But that's 56 patients have a mortality of 35 versus ECMO only 3 to have acute lung injury and 1, have a tracheal tear and bronchial laceration and bronchopleural fistula, and 1 had the ECMO who did not survive, but the rest did survive. If you go to the severe lung injury score, look at the mortality on the no ECMO group, 100% mortality with a p-value of 0.004, comparing to 36% mortality in the very, very severe ARDS that use ECMO. this is really give you a delineation. You know, it's a retrospective analysis, but it's astonishing number: 100% mortality versus 36.8 with a p-value of 0.004. If you look for the timing of ECMO, which I'm not entirely sure how to explain it, but if you start ECMO early, based on this retrospective analysis, the survival is better, 66 versus 33. For different reasons, that it's difficult to delineate which is the cause for that, but this is a fact that I thought maybe we have to share it. And if you look to AKI, I think that was a really delineation, you know. From all the variables that we have, multivariable logistic regression analysis to predict mortality, if you look to the number, there is only two things that's striking: is acute kidney injury and brain edema. Anything else cross one with a p-value that's not remarkable, but acute kidney injury, look at the p-value, 0.001, and the odd ratio is 13. Brain edema is 4 and 0.0037 of p-value. Brain edema is understandable because it's a severe acute traumatic brain injury with brain edema. The likelihood of them surviving, the lung is okay, but if the brain is gone, brain is gone. But acute lung injury, look at the number, it's really astonishing. And when you look to the subgroup analysis, so in the ECMO patient and the non-ECMO patient, you can see with AKI, look at the mortality in the ECMO group, 54% mortality. And without AKI, 11% mortality. That's really remarkable. And even in the non-ECMO group, look at the mortality with AKI, 80% versus 25%. Both are still high, but is a significant delineation. And this is just give you the number who survived, who died, and who had a complete recovery of the kidney. So acute kidney injury in the setting of traumatic ARDS, I think it's probably a factor that they need to be considered carefully. And brain edema, obviously, finding the right prognosis for the brain, I think it's very, very important as well. If you go to the bleeding on ECMO, most of these patients, actually, we run a heparin-free circuit. And you can see the number of head injury on these patients. With ECMO, 68% had actually traumatic brain injury, but we did not have much cerebral bleeding was observed. 3 patients with traumatic brain injury died in the ECMO group, but was not the cause of the bleeding. And ECMO with a heparin-free strategy was actually safe as long as you is no active bleeding, obviously, and you drain the TPI. So if there is any drainable bleed, drain and control, then I think ECMO can be utilized. So just take, I think, going to take home message. I think time has come. We should not deny life-saving ECMO therapy to trauma patient. This is before or after my paper. I think this is my belief, and we should not really deny that. However, we need to select our patient carefully because decision to start is not easy. We need to consider individual variation. We need to have more data to understand who will benefit. And that takes us to next step, you know, and I think the next step should be a prospective multi-center observation followed by a randomized clinical trial. And we need to get the trauma centers who do ECMO working together to get more patients and try to study and identify and learn more about this patient and see who will benefit from that. And the future might prove to be bright after all for ECMO and trauma. With that, I end my talk and thank you all for your attention and happy for question and answer session. And hopefully we see you in Qatar in FIFA World Cup. If you cannot make it, we'll watch it on the TV, but enjoy it and thank you very much. I back to you.
Thank you so much, Dr. Ibrahim, and that's really nice review. In addition to the study you were guys managed to publish it. Although through the presentation I was seeing, I was thinking one thing, like, what do you think is the thing coming to your mind as an ECMO intensivist when you've been called for trauma patients desatting? What's the most alarming thing that's going to come first to your mind?
So I think you know, when we get this call, we really are worried from. Can you see me, Aid? Sorry,
Yeah,
apology.
I'm
I
seeing.
think,
Yeah, I'm
yeah,
seeing.
I think,
Yeah.
it's really the prognosis from the brain, really,
Oh
that's
yeah.
really matter.
Yeah.
To identify what's their initial Glasgow Coma scale on presentation, mechanism of injury and the severity of the injury, the polytrauma, the severity score of the trauma, all these trauma indices, I think, are important for more survival assessment. However, it does not stop us from doing ECMO for these patients. The key for us is actually brain prognosis. If we can have any hint that there is a chance of brain recovery, because remember, majority of these patients are young, and their recovery potential is very, very high. Now, from the study that we reviewed, and learning from the cases we done, AKI, I think, need to be considered. I don't think I will deny patient ECMO just because they have AKI, but it will just alert me. And I think two of the AKI patients that die in the ECMO group, I remember correctly, actually was brain edema, and probably the technology maybe affected that, or other factor. I think need to be studied more. But when you go at the bedside and assess, I think neuroprognosis is a key. If you have devastated brain injury, with a consultation of neurosurgery, maybe you could deny that. On the other hand, you get many consultation. We get many consultation, and with a simple bedside optimization and a prone position, if applicable, lots of these patients actually get better, and they improve without the need for ECMO. So you need to look at the two potential is what's the prognosis, when to say, what, we cannot offer that based on bad prognosis. On the other hand, we cannot offer that because the patient actually does not require ECMO, and he will improve with a very good vent management strategy, prone position, fluid removal, and other simple thing that you do for your ERDS patient, but a bit more aggressive. They will benefit. There is other patient that you cannot wait, and
Yep.
prone position is contraindicated, and their CO2 is high, their intracranial pressure is high, and you see, you don't want to wait, and there is no other contraindication, then you go ahead as a bridge for decision, and then take it from there. And several patients that we had that bridge decision actually did very well, and they were weaned completely from ECMO.
Well, so that's really interesting. I would ask, this is the last question for me, then I will open the stage to receive questions from the attendees here. So if you can open the chat, dear Rose, so the people can be able to ask the questions. So what was the longest period, Ibrahim, you had you guys there to keep the patients on ECMO post trauma?
Not long, guys. The trauma patient usually do very well, or they don't. But whoever will get better, they get better quickly, because these are usually young, healthy adults who has no chronic illness most of the time, who come in with acute injury. Once you fix it, and they need a time to settle down and their lung recover, and it's not like COVID that stay for long, or Staph aureus that destroying your lung. That's a bit different, obviously. So majority of these patients actually, I think within 3 weeks, they get better. Majority less than that, 10 days to 2 weeks, the lung will improve, and that's what keep you. You don't want to deny that, because that's not a really long stay on ECMO, and when you think about capacity and how many patients you have in service, the trauma patient can actually will not add a lot to your capacity, because once they are better, we transfer them back to our trauma colleague who do very, very well management of post-trauma care and rehabilitation.
Well, that sounds great. So I think till we able to make the chat ready for people to ask the questions. So the one of them, like your what's coming through the statistics you find, guys, through your study was ECMO showing the same, I think, like mortality at the end of the point compared to the people who didn't receive ECMO. Am I right?
It was not statistically significant. The ECMO group has a better survival, looking to the numbers. However, it did not reach a statistically significant to say it worked better. But on the other hand, you can see the group, if you think about it, we are ECMO center and trauma center, and we get referral. So if I get a referral with a, lung injury score of 2, why should I put this patient on ECMO in the first place? So to compare, I think you really need a perspective, and you need to be define, okay, Murray score of 4 here, Murray score of 4 here. Which one would you give ECMO? I think it's a bit unethical to deny ECMO for these patients. So it's a very difficult to construct the study, However, I think this study was very good, because when you look to the subgroup analysis to the patient who has a severe lung injury, they did very, very well on ECMO, 35% mortality compared to 100% mortality on the other group with a p-value of 0.004. Obviously, it's a single center study, but it clearly shows significant delineation.
Well, that's obvious, actually. Do you think that's what I mean? In the future, like requiring getting more like cases, and depending on what you mentioned, like in the through your presentation, that getting a center who's good at our trauma and good at ECMO in the beginning is one of the better choices. Let's say choice A for doing such studies. But how about like transferring patients from other centers of trauma to a center of ECMO? Do you support that?
Yeah, this is very interesting. I will start with the second point: transferring from a trauma center to an ECMO center. Well, trauma patients are complex, and they require really a specialized team to take care of them from the trauma perspective. It's a bit difficult because depending on the ECMO center, some of the ECMO center are run by cardiothoracic team, some are run by intensivists. Most of the nurses are not trained on the trauma management. And I think that's, yes, you can do that if you have no other options, but it would be best to be nursed with an ECMO team, obviously, but surrounded by an expert trauma who could help and follow. So when we transfer these patients to our ECMO unit, this is with the same hospital. The trauma team will follow with the patient with us, and their input is amazing. It's valuable. It's difficult to manage these patients alone unless you are a combined ECMO and trauma consultant with trauma nurses and who have ECMO capability as well. That would be ideal. But transferring them and deprive them from the expertise of trauma, I don't think is the best option unless you have no other option. You will think what will kill this patient now, and how can you prevent it? If the ECMO is the one that's gonna stabilize, then you do that, and then you transfer them back. But ideally, you should have these centers together. You should have this expertise together, and that's why tertiary quaternary center. It have to have the trauma, it have to have ECMO, it have to have transplant, have to have pretty much all the standards. So you need to have these center in your place or close that you can refer, that they can do the multidisciplinary management of the trauma and ECMO at the same time, with neurosurgery input, with orthopedic input, with all the specialty input at the same time. Trauma nurses, the critical care nurses of their management. Same for burn patient, burn patient who require ECMO, what are you gonna do? Burn nurses are specially trained. They have agent management of burn patients. So ideally, that should be all in one center, if possible, obviously.
Well, that's great. Rose, are we able to activate the chat here so we can get some questions from the audience?
Doctor, they can just raise their hand because I don't think that we have the chat here.
So we couldn't get a chat.
No, we don't have chat here.
So can we go over the audience? So like taking like 3 to 5 if you don't, if you allow me, Ibrahim. So if you can
Yeah.
like 5 maximum as a questions, and we hear from them. So if you can go to unmute people who are raising their hands, so you just unmute one by one so we can get a question. So one question, guys, is allowed. Dr. Ibrahim is on a trip actually in England, and he's still doing his talk today. So if you don't mind, guys, so we'll be taking the first like 5 raising their hands and their questions one by one. If you can go, Rose, to start with the first one.
السلام عليكم معي.
Salam wa rahmatullah. تفضل.
This is Adib Kawaji, pediatric intensivist. I would like first to thank you and the speaker about this great lecture and reviewing this important topic. I have just a dilemma in my brain rather than it is a question for the speaker. Because for those patients who has trauma with multiple injuries, especially who has lung injury with a brain injury, and the decision to bridge this ECMO while you don't know what is the prognosis of the neurological system after 72 hours, and the legal and the ethical issues about withdrawing care if this patient has significant clinical deterioration in his neurological status. So I would like to ask the speaker about his experience in this situation and what he thinks once we have the brain injury with the lung injury.
Yeah, so that's a great question. Thank you very much for that. And maybe I think for the other people who's unmute, if you can just mute yourself temporarily so we don't have an echo in the voice. What I will say is it's difficult. It's really difficult to delineate who will benefit and who will not benefit from ECMO. And neuroprognosis can carry a dilemma. There is a clear patient who would have. I think you guys need to just mute yourself. Yeah, that's better. So I think to answer this question is there is a clear patients who they have a severe injury. Their brain injury is devastating. They have a severe brain edema, and very clear that these patients will not recover. We will not offer ECMO for them. But there is a patient who also are in the hazy area, axonal injury. We heard this a lot. Oh, they have diffuse axonal injury. They are not recover. Well, we put several patients on ECMO with that. They completely recover and went home. So it's really difficult to do. And I think the thing that pushes you to do it is first, you should have the experience from the ECMO perspective, is that input from the trauma team and neurosurgery. It's a multidisciplinary decision that I need to be taking. It's not one person decision, but I think in combination of all this expert together, putting their input, you probably will have the best answer at the moment until we have more data, and that's what we need to do. We need to study this population more. But you can see, with a traumatic brain injury, survival, and severe lung injury as well with polytrauma, the survival was not dismal. The several, I think 60% survived. That's very good, And if you put this patient without ECMO with severe lung injury as well, very high mortality in this group. I think we need to learn more. It's a great question. I don't think I have the answer for it, but we are learning. From the ethical point of view, once you put them in ECMO, and you know what, their oxygen exchange is better, hemodynamics is better, but you know what, they are brain dead. What do you do? And it's depend on the center, and the country. Usually the ideal situation is actually withdrawal of care with a discussion with the family, and depend in the regulation in the country where you are. In Western countries, pretty clear, it's easier. It's a brain death defined, and you have to switch off the sweep and or properly to do that study. But it's a withdrawal at least of the ECMO therapy. In our countries, it's a bit difficult. And that's why we talk to the family up front before we start ECMO, and we tell them, listen, we have no control on the brain injury and the prognosis of it. But if they reach a stage that they are brain dead, we have to withdraw. And a lot of family will agree, and some will survive, some will not survive, but it's not easy, it's difficult.
Yeah, I can't agree more with that really opinion. Like the situation will be difficult once that included with a brain injury and reaching the level for brain death. Well, Rose, if you don't mind, can you choose a second one, please, and presenting yourself and your question to Dr. Ibrahim. Go ahead.
Miss Flor de Lisa Ibanez.
Yes, dear. Go ahead.
Miss Flor de Lisa Ibanez Sarasa, please. Do you have question? Or Jonaline Vergara, do you have question, dear? I think, doctor, they just accidentally raised their hand, but they don't have questions.
So whoever.
Dr. Amir Abdelkader.
Go ahead.
Assalamu alaikum, Dr.
Alaikum assalam.
Cardiac assist. I just want to ask about how the approach to handle hypoxia after ECMO insertion. The approach.
Okay. So if you mean persistent hypoxemia despite full ECMO support?
Yes.
This is a very, very interesting question. Our team have been giving actually a simulation course focusing only on this topic of management of persistent hypoxemia. We give it in ELSO, Euro ELSO, Latin American ELSO, in Paris course as well. So it's a big topic, and I don't think I can summarize it. But in general, there is a certain strategy, and if you read the ELSO Red Book chapter on that, is very well written, and in the guideline as well. And there is several paper actually were published on that on this topic in general. Number one, obviously, you have to increase your ECMO flow. You have to identify the cause of hypoxemia on ECMO. Is it recirculation? Is it access insufficiency? Is it machine-related injury? Is it a patient-related pathology from increased consumption or increased intrapulmonary shunt or increased oxygen demand? So that's have to be diagnosed, and based on that, you do your treatment. If recirculation, you treat it. If it's machine-related factor, obviously you have to fix it quickly. If it's related to intrapulmonary shunt, which is most of the time it's the case, you need to decrease the patient cardiac output and improve the ECMO flow so you can decrease the percentage of intrapulmonary shunt. That can be done with many things that decrease patient cardiac output, sedation, beta blockade, sometimes temperature control, but they also will decrease oxygen consumption for the patient as well. So I think it's a great topic. Sometimes we add additional cannula, do hybrid configuration, but it's we usually give a talk about that for half an hour just to discuss that in detail, and I don't think I'll be able to do that on the talk. But it's something that if you want, we can share several presentations that we have done on that with you, or you are welcome to join our SIM course. We have a particular course just for management of hypoxemia on ECMO with different scenarios, and really, once you finish this course, it makes you ready to manage any hypoxemia on ECMO.
Excellent. I'm seeing one of our seniors. I think Dr. Azam is around. If you can.
Okay, Dr. Muhammad Azam.
Dr. Muhammad Azam is the champion for the ECMO, and he's the head of the ECMO all over the kingdom. Go ahead.
Assalamu alaikum, Ibrahim. Thank you very much for your great talk, and Ayat for hosting this webinar. 3 fast questions. What configuration would you use in a trauma patient? You have a default configuration or based on the patient. High flow versus low flow in trauma. Anticoagulation or no anticoagulation?
Mohammed, first of all, thank you very much for the question. It's great to see you and looking forward to meet you in Saudi Critical Care Conference, inshallah. So the first question is what configuration? We usually prefer to do FEM unless there is an injury to the pelvis and injury to the lower extremities. Then we go to the jugular. But you can really do any configuration based on the patient requirement. We prefer high flow for one reason is we run a heparin-free circuit and we don't want our circuit to be clotted. And for that, we try to do high flow. High flow not means 7 liters, anything more than 3 liters. If it's maintained the oxygenation, that should be okay. We aim for heparin-free circuit in trauma patients, especially with the bleeding and traumatic brain injury. Sometimes we use a pre-membrane heparin only 500 units per hour. But no systemic anticoagulation, and the membrane can stay for a long time really with the new technology. We run it in several patients, and remember these patients with a trauma, they improve really quickly. So 2-3 weeks and majority of them get better, and the membrane can survive that without anticoagulation.
Excellent. So I think by Dr. Azam's question, we are about to reach the end with our guest, which is really one of the interesting talks that's been really thrown through or posted through the Saudi ECLS chapter of the Saudi Critical Care Trial Group. So we are really happy to, or having really an honor to hear from you, Dr. Ibrahim, although with all of your circumstances ongoing. So wish you the best, wish you a safe trip back home. The talk was amazing. Your trial, guys, is really promising and is going to open the route for multiple really other trials towards answering a lot of questions in ECMO and trauma. I think that was one of the greatest really talks that I've been involved in. I'll leave the last message for you, Dr. Ibrahim, if you want to mention anything. And after that, we are joining, and thank you so much for everybody who attended. Thank you.
Well, first I have to thank you, Ayed and Mohammed and the team from Saudi Critical Care Society for this great webinar. I think we need to do more. It's always a pleasure to work with the SCCS-ECLS chapter, working with you guys, and I'm sure you have plenty of experience to share as well. And I think it's we need to work more together on the research, and I'm pretty sure there is a plenty of strong trauma centers in Saudi Arabia and in the Gulf region that we can start working in collaboration, step by step, working with ECMO-Net, with also obviously, to get more and study this group of population more carefully, because they are unique. They have a good prognosis if they pass this brain injury part, and if they get through initial trauma management. If you get them through, they are young, healthy adults who can really do very well, and there is many data of heparin-free circuit that can be utilized without increasing the risk of bleeding in the trauma patient. So I think time is coming to really work together and to facilitate that, and we are open for any collaborative work as a group. With the end, I'm sorry again, I just reached the airport. Is not the best environment here, but I'm very happy it went well, and great feedback and a great moderation from you, Ayed. And looking forward for meeting you guys in Society of Critical Care, Saudi Critical Care Society.
Sure, thank you. It was not only your talk, is even the weather, so it's a chance to get some pictures from your background. Then really, that's one of the amazing really talks that I've been involved in, and with a good mashallah attendees for that talk. And at the same time, I would really take the advantage of the moment to ask people not to miss your talk again in the critical care suicide in Saudi Critical Care Society conference coming to Jeddah. So really, it's a chance to meet Dr. Ibrahim and his experiences in general critical care. Thank you so much, Dr. Ibrahim. Thank you for Rose. Thank you for the pediatric ICU chapter who allows for hosting this talk and activities. Thank you so much for everybody.
Thank you, doctor. Good night.
Good night
Thank
for
you.
all.
Bye-bye.
Thank you. Bye-bye.
Bye-bye. Bye-bye.